I want to run down some of the current treatment landscape
Sure.
that we've got over here. We've got concentrated factor VIII, factor IX, clotting factor, human versus recombinant. We've got prothrombin complex. We've got cryoprecipitate, fresh frozen, you alluded to that, desmopressin, aminocaproic acid, tranexamic acid, fibrin sealant. I know before we went on the air, you were talking specifically about fibrin sealant, something I never knew. What's going on?
Many years ago, surgeons, such as yourself, would use it like water in the OR. And this contained factors derived from cows, bovine factors, factor V, particularly where patients who did not have hemophilia or any problem will make antibodies to that and would cause all sorts of concerns later on when you wanted to use it.
You know, it's funny. I used to watch the surgeons squirting this stuff on coronary arteries.
Yes.
We thought it was a gift.
It works great, but since that time, that problem has been eliminated by using purified human.
Okay. What about storage, preparation for all these things?
So these are all proteins that can be stored for, now all the companies can install these for months at a time. There's even certain companies that will advertise that you can leave it in a back of a car at 88 degrees for X number of hours and it's still stable. So they've gone to great lengths to stabilize these proteins and make them, and also to reconstitute them so the volume that you infuse now is basically down to just a few cc's, when many years ago, when we were talking about earlier, would take half an hour or an hour.
How many cc's would that be?
It would be anywhere from, depending on your weight, because these are weight-based, anywhere from 30, 60, sometimes even more cc's.
In the old days?
In the old days.
And now it's just a few cc's?
And now it's a few cc's.
Can you give them push, or do you still have to give them
It's
a drip?
push. It's
Really?
a push. You could, I mean, a slow push.
There are different formulations out there, right, with different half-lives. So what are the risks and the benefits here of these different formulations? What are they, Bob?
Sure. So, we've had, first they start off with plasma-derived concentrates. So those are factors derived from human plasma. And then because of the HIV and hepatitis complications, they shifted to recombinant in the late 80s and early 90s. And, but by then we've actually been able to eliminate that issue from plasma-derived products. So I don't want to state that they're not safe now. They are safe. But we have those recombinant products, and the limitation has always been the half-life. So for most factor VIII concentrates, the half-life is somewhere between 8 to 12 hours. So you can tell if you infuse somebody at 100%, within 8 to 12 hours, they're already down to 50%. Wow. So by the next morning, they're down to 25%. So you can see the limitations, and so that's been the practice for a while. And about 5 to 10 years ago, the company started making what we call extended half-life products. Right. And so for factor IX, they've had significant improvement, and so they've been able to increase the half-life by 4 to 5-fold, which is a significant increase. And so patients could infuse once a week versus 2 to 3 times a week, which is a significant improvement.
It's huge, actually.
For kids, that's great, and even adults as well. But in the factor VIII side, they really haven't been able to get past. So typical, it's 3 times a week or every other day for standard half-life. And for extended, they've been able to get to twice a week, which is a slight improvement, but obviously, there's the limitations. So they've hit a ceiling in how well they've been able to get. So.
Are there adverse effects to clotting factor treatments, other than just getting the needle and doing it several times?
So, there are always the chance of reactions, hypersensitivity reactions. Those are relatively rare in general, and obviously you have to dose it correctly or you risk things like blood clots. But the biggest risk factor, and the thing that's been a huge problem, still the hugest problem in hemophilia is the develop of neutralizing antibodies against that exogenous factor or the infused factor.
So the body says, wait a minute.
Yeah.
I haven't seen factor VIII or whatever factor it is. This is new to me. I'm going to develop an antibody. Good luck with that.
Yeah, exactly. So if your body doesn't make something, it's trained that way. If you don't make something because you've deleted it in this, and you infuse a large amount of this foreign protein, your body sometimes can react and say, oh, this doesn't belong, I'm going to get rid of it, just like it would a virus or a bacteria.
So you're making antibodies.
Yes.
Not only does the stuff not work with those antibodies, the half-life doesn't change.
Yeah, so it actually, these are IgG antibodies. A third of the patients with hemophilia A will develop these, and unfortunately they develop in the first 10 to 20 exposures. So you're talking about developing it typically in the first 3 years of life. And then it becomes, some of them antibodies become so strong, as soon as you infuse it, within 15 minutes, it's all gone.
How common, in other words, in the landscape here,
Sure.
if you're giving factor 8
Yes.
to all comers with
Yes.
hemophilia, how many of them will get antibodies?
So in the severe patients, a third will develop it.
And 2/3 won't.
Yeah, and 2/3 won't, and a third of those, and so about 60% of that 1/3 will develop high titer inhibitors that are very difficult to clear. And then about 40% of them, for the most part, we can clear it with aggressive therapy. And it's much less common on the hemophilia B side. It's somewhere in the single digits.
Okay.
But that has its own challenges because they can develop anaphylaxis, nephrotic syndrome, all kinds of horrible stuff can happen. And we have almost no
hate
data.
that, by the
Yeah.
way.
It's awful, and those are incredibly difficult to treat. We have one patient right now
I mean,
that's
you give this
difficult.
drug and the kid falls apart right in front
Yeah,
of you.
yeah, and they typically, what happen is the mom will say they're not responding, he's bleeding a lot, he's oozing a lot. We come in and we test them and they have an inhibitor, and everything changes. They thought severe hemophilia was bad, and now they're at a whole other level of badness.
What is known about inhibitors is that the more severe disease you have, meaning genetically you have a worse kind of mutation where there's no protein, and there's family history as well. Blacks have a higher inhibitor rate than Asians, whites, or even Hispanics. The field of inhibitors is fraught with the fact that we really don't understand exactly what's going on, other than when you introduce this protein, especially to children, the first 50 infusions, you're at the highest risk for an inhibitor, really the first 20. And if you get past that, the odds of you developing an inhibitor drop, but never go away. I have patients who are in their 60s that never had an inhibitor, that were taking infusions and developed one.
So what are the things you do to avoid complications other than inhibitors? We'll get to inhibitors, but is there any other complication from these?
Apart from the bleeding complications, not so much.